This will be the second part of cardiovascular. And before I do anything else, though, y'all have your MATLAB programs for this or whatever. Maybe you can even do this by hand, I don't know, but this is the formula that takes that number up in the top in red on your papers, and you apply that in this formula, and you will get your percent score. Now, what I had to do, because the mean was a little bit below 85, where I like it, I goosed up the scores a little bit. That's where that extra 2.4 number comes from, is so-called curving the grades, or making it, normalizing it to the distribution that I wanted. Okay, so that'll give you a percentage score. Now, then what you can do, if you go back to the very first lecture, you can see where your grade falls within the letter range, okay, between 90 to 100 is an A, and 80 to 90 is a D, that's that kind of thing, so you can do that. I do want to put this on Sakai, but Sakai gradebook's a little funny in the way it interprets scores, so I have to, before I do that, I'll make sure it's okay. So anyway, that's that. We'll, kind of discuss maybe next time if there's any implications for some of you on this. Word of the day. Who wants to do the word of the day? Nobody over in that corner in the blue shirt?
I will. But I have a choice. So, ology is the study of something. That beginning part has something to do with an outer layer of skin, I believe, but I'm not exactly sure how that word breaks down.
The prefix means to be over or be upon. And then beginning, what's that mean?
I think that's skin or tissue or something.
Democracy. You've heard the word democracy means government by the people. So demos by the people. So this is a word that's hard to break down. It means upon the study of something upon the people. Okay, epidemiology is the study of disease patterns in people. You might have heard the word. So that's, it's kind of weird breaking it. When you try to break it down, doesn't make much sense. But that's what it means. You look at, I think some of you will probably maybe involved in research projects that are epidemiological or epidemiology in nature, that kind of thing. So you're looking at, say, cancer induction by radiation, something like that. So, but that's how you break it down. This is basically what the word means. I think we'll go ahead and continue with arteries and veins, and we'll do a little bit more with the heart in the remaining time. But I do want to say a little bit about the extremities, especially upper and lower extremities. Oops, sorry. Have arteries. This is the upper extremity, the arm, and we have a subclavian artery. Okay. Comes off the brachiocephalic artery on the right. This is the right arm. Left arm's a little different. The brachiocephalic trunk doesn't supply it. It's the left subclavian artery. Comes down here, and then it changes its name, branches out until you have a brachial artery here. The word brachia, it just means arm in Latin. So you have deep and superficial brachial arteries. Branches down into two arteries here, the radial artery and the ulnar artery. This runs next to the ulna, which is the sort of non-weight-bearing part of the upper extremities, and then the radial artery runs along the radius. And then they both branch down to feed your fingers and hands. Okay. Now, the fingers and hands are pretty important, right? You don't want to lose blood supply to them. So, you remember that circle of Willis in the brain? Gave you that redundant blood supply in the brain to two hemispheres? Got one in the hand. They don't call it that. It's the palmar arch, where you have the collateral supply between the radial artery and the ulnar artery. And the reason that's good if something happens to your radial artery, you have an intact ulnar artery that will continue to supply your hand. So this is very important to somebody who's doing angiography, because they may want to put a catheter into the radial artery. It's one approach you can use. It's a lot more comfortable for the patient to use it rather than the femoral artery. So that they'll use it, they'll run the catheter up here and then down into the heart where they want it. Okay, and it's also a shorter trip. So that's good, but if you injure this artery, and for some reason your ulnar artery isn't patent, it doesn't work, and you injure the radial artery, you don't have any blood supply all to your hand. So the doctors do a little test called the Allen test right before they do this. They have the patient, they open the palm up and they squeeze on the ulnar artery and then let up on it. And if the hand continues to blanch, then you see blood flow back to it. You can see if you rate the ulnar artery is patent, so you can go ahead and use the radial artery. There's a bunch of veins that, it's similar. Like I say, there's some duplicity. It's not one-to-one exactly, but each artery has an associated vein to return the blood back up through all these veins. There's the so-called median cubital vein. It's in the antecubital fossa. Anybody have a blood sample drawn? People might use one of the little branches of it off to the side here. Common one. So usually pretty big and nice and fat. And there's one over here too that they could also use. And then you can do angiography on them. This is a brachial artery arteriogram. Again, they put the catheter in somewhere up north here, and then with the blood flow, they injected the contrast, and you can see the two arteries. You notice that there's a lot more flow of contrast in the radial artery. It's a larger artery than the ulnar artery, but still, this is enough to supply your hand if you need it. We'll look at the aorta in a minute, but the final branch of the aorta is something called, splits into the two common iliac arteries, and named after the bone in the pelvis, the iliac bones. So you have these two common iliac arteries, and there's a bunch of, as we'll see, arteries that branch off this, like the femoral artery. But you'll notice is one of the things you can see in a contrast. Let me turn the lights out a little here so you can see it's better. A lot of little arteries come off here. And what you can see, if you look carefully right here, there's a little bit of what is called a blush of contrast in some structure here. So what structure down in the pelvis might this be in a female? Uterus, yeah, this is the uterine blush, they call it. These are uterine arteries that come off the common iliac arteries. Do have arteries and veins in the lower extremities, of course. And so here's your common iliac arteries branching off the aorta. And then you branch finally into the femoral artery. And this is, again, you can put a catheter in right in this vicinity right here and snake it up into the heart, too. The problem with using this is it's kind of, if you put a needle in an artery, what happens when you take it out? It bleeds, okay? Especially in people who have poor coagulation. It'll bleed, and it'll bleed a lot. You have to put hours worth of pressure on this artery to make it stop bleeding. And that's not good for the patient. Whereas if you use the radial artery, it's not nearly as long. So it's a good artery to hit. It's easy to hit, but it has its issues. And then it branches out in a whole bunch of little arteries down the lower leg. And also there's the equivalent of a palmar arch down the foot. And basically our feet are kind of a lot like our hands, although the functionality is very different. And then again, you have veins that return the blood that are similar in distribution to the arteries. The femoral vein that you have down in here, you can use that if you want to get to the right side of the heart. You'll go up through the inferior vena cava, up through the liver, up through the diaphragm to the superior vena cava, and then into, say, the subclavian vein, and then down to the right side of the heart that way. Or you can go directly from the superior vena cava also into the right side of the heart. So it depends where you want to, put your contrast and what you want to look at. This saphenous vein, great saphenous vein here. For some reason, they're able to remove parts of this vein, and there's enough so-called collateral flow through the femoral vein that you can actually sacrifice this vein. Anybody want to know why a surgeon would want to do that? Why would want to cut out part of this vein and tie off the other two? It's a very good source of veins and arteries for a coronary artery bypass graft. Okay, if you have a blocked off coronary artery, one way to unblock it is to bypass it. Okay, so you take part of the saphenous vein and make that your root bypass. It works pretty well. So that's what's done. So you have two teams in the operating room, one operating on the heart, getting it ready, and the other operating down in the leg to get the saphenous vein. This is kind of important. We'll go over some of the details later. We're not going to say much about the little branches that come off that feed the esophagus and the vertebral bodies. But we will say a lot about some of these major branches that feed your liver, spleen, stomach, intestines, kidneys, that kind of thing. We'll look at those individually on angiograms. So what you'll want to do is to learn the names of these arteries, for your study purposes, for the exams. And we won't talk too much about this, but also make sure you learn these. Okay, the brachiocephalic trunk, left common carotid artery, and left subclavian arteries. So let's look at those individually and see what they supply. This is something that's not done very often, this abdominal aortogram. You're looking at the entire aorta. You're not selectively putting your catheter in a particular arteries that you want to look at. Why would we want to do this for the whole aorta? There is a defect in the aorta. It's called, you may have heard of it, called an aneurysm. It's like a balloon. The inside, the inner lining, or the intima of the aorta bulges out, has blood going underneath the intima. And what can happen if you have an aneurysm there and it bursts? You can fill your abdomen up completely with blood and you die very quickly. So you really need to diagnose small ones before they get bigger. And that's, some people use an abdominal aortogram for that. You might want to do something in the aortic arch. You can do that as well. But in this particular case, it shows all the vessels here. And it doesn't show them very well. So that's why you want to do selective angiography, not put contrast in the whole aorta. So you can do that, and this is, again, that technique called digital subtraction angiogram, where they take a picture before the contrast is injected, have the patient not move, and then do it again with the contrast, and then digitally subtract them. So you can still see, though, you can see the catheter coming up. It's not totally subtracted out here, but you can see it. It goes here into the big vessel, which is the first big vessel as you go down the aorta into the abdominal aorta. It's called a celiac trunk or celiac artery. You may call it, means the same thing. So put your catheter there and put the contrast in, and it'll go to what is called the common hepatic artery, which has many branches to the segments of the liver. We'll look at liver anatomy a little later, but liver, like the lung, is divided up in segments. So each segment has its own blood supply, but the common hepatic artery feeds all of them. Another artery, big artery that comes off the celiac trunk, is the splenic artery, and this goes to the spleen. The spleen is a very vascular organ. It has a lot of blood vessels in it and a lot of blood supply. The spleen you can almost think of as a big lymph node with a lot of blood vessels, and its job is to not only have some immune function, but it also, like other lymph nodes, but it also takes out stuff from your blood. And that is pneumococcal bacteria, for example, also takes out dead red cells. A red blood cell has a lifespan of about 120 days in circulation, and then it gets all crenated, it means shriveled up, and the spleen takes it out. So that's why it's got a really good blood supply. You can go down one more vessel. Okay, the celiac trunk's up here somewhere. You're down to the superior mesenteric artery, you just hear, and you put your, here's the catheter coming up. It goes like this, and then the branch, and they put the contrast in. Now you see a lot of things, being opacified with contrast. This is not a digital subtraction angiogram because you can see bones and everything. It's just a normal one. But you can see arteries that are named for the territory they supply. For example, this ileocolic artery supplies the terminal part of the ileum, that's the last part of the small intestine, and then the first part of the colon. Then you have the right colic artery, which supplies the right side of the colon, and the middle colic artery supplies about half of the part of the colon is called the transverse colon. Colon does this, goes up here like this, moves over down here, and then goes back down. We'll see that in the GI part of this course. But so it does all that, and there's also some intestinal branches that feed most of the small bowel. So this single superior mesenteric arteriogram shows you how the blood supply goes to the left side of the colon, the middle side of the colon, and then the small intestine. Then finally, go down a little bit more and you get the inferior mesenteric artery. Again, this is non-digital subtraction. You can see the catheters coming up here. And so you put your contrast into that artery and you see where it goes. It goes over here, over to the right side of the colon, okay, and down. Okay, and then down and feeding the sigmoid colon and the rectum and structures down in there in this inferior mesenteric arteriogram. What does the word mesentery mean? Mesentery. We'll get to that in the GI tract part of this, but it is basically a folded membrane that contains all the blood vessels and nerves and stuff that go to your small intestine, your large intestine. So that's what mesentery means. Okay. So the other thing you can see if you do a digital subtraction angiogram of the inferior mesenteric artery, you can get a real good idea here. Here's your catheter. Get a real good idea of this. You see this feathery appearance? This is blood vessels in the right side of the colon. And when you think about it, your intestines and your colon are going to need a big surface area and a big blood supply, okay? Because they have to absorb all the nutrients and water and everything else that you take in as food. So this kind of, they call this feathering. This is just the kind of late stage of this angiogram. And you can see this really, really rich vascular supply here. So you look at some of the bigger veins that we haven't talked about yet. If you take and remove everything else, you can see the azygous vein and the hemiazygous vein. I guess they call it the hemiazygous vein because it's about half the caliber of the azygous vein. I think this vein drains a lot more structures, but mainly they drain the structures in the chest that are not lung. That's one of their functions. What about the veins of the posterior abdomen? You can take out everything and you're left with structures like kidneys. They are behind the membrane called the peritoneum. So we call them retroperitoneal. So if you take all the intestines out, you're left with all this stuff. And again, you can see, here's the aorta. This is the descending aorta. And it branches out into your common iliac arteries. Then there's, the veins that are, collateral to it go up and drain the kidneys. And it's a big, big function. The kidneys get about 25% of your blood flow. Each heartbeat, about 25% goes to the kidneys. And this is kind of a reflection of their purification function. As we'll see, they have other functions as well. There's something not unique exactly in the body, but it's very important, and it's called a portal system. Now, portal system, all it means is you've taken your venous drainage, and you've put it this is from the capillaries in all these organs. These are the venules and these are the veins. They all drain into this large vein here that goes into the liver. This is the hepatic portal vein, okay? And then there's a second capillary system up here in the liver. So all of the portal system is two capillary systems in the same venous drainage. And we'll see why that's important in the gastrointestinal part here. But what it means is that all the blood that is draining the colon, it contains two things that you need. It contains nutrients, all the nutrients that are absorbed by the colon and by the intestines, okay, are sent to the liver for the most part. All of the poisons that you get, either generated in the body by the process of digestion or things like alcohol or other poisons, they can be broken down and detoxified by the liver. So the liver's got two jobs. It's got to take and process all those nutrients that come from the blood supply, which is good, and it also degrades some of the toxins. So that's a second capillary system. So we'll see a little bit more how that works later. But eventually, the capillary bed in the liver, after it's done its absorption and detoxification, will drain into this inferior vena cava. The inferior vena cava contains all the blood that has come back from everything below the diaphragm, pretty much. Okay? Once it crosses the diaphragm, it becomes something called the superior vena cava, and that will ultimately drain into the right side of the heart, right there at the opening to the sinus. Okay, so we'll see how that's important when we get to the gastrointestinal tract. But that's what a portal system means. There is another one that I can think of, and it's related to the pituitary gland in the brain. There's a portal system there too. And we'll see how that works. So going back and reviewing a little bit, you have this other basic plan diagram of blood flow. Okay, so you have your systemic capillaries out here. Okay, and the rest of the brain and all the rest of the body. You have these capillaries, and they drain into various veins that go into the right side of the heart, from the right atrium into the right ventricle, and then back to the lungs to be oxygenated, and then back circulate back through the arterial system again. So we've seen that before. But how does that work in detail? There's something that's called the cardiac cycle. If you remember those two words we talked about, systole and diastole. Systole is when both ventricles are maximally contracted, and diastole is when they're maximally expanded. So it's a cycle, though. You have to go from one stage to another. So, for example, in this diagram, they're starting out at diastole up here. Okay. Rather, this is actually step one. This is the beginning of systole, the end of diastole. So what has happened here is that there is something that they call an atrial kick. And this is the atria start to contract. It's atrial systole. Okay. That ejects weakly blood from the atria into the ventricle. There's a little pressure gradient so that the blood will go from the atrium into the ventricle here. So you get that. And this is when the ventricles are now, will contract a little later, this next phase here. So the ventricles will begin to, they don't contract exactly, but they, it's isovolumetric, ventricular contraction. What this means is they're starting to contract, but the volume in here is going to stay the same. So as this contraction progresses, these valves will close. The mitral valve and the pulmonary valve will close off to permit this to happen. Remember those chordae tendineae and those capillary muscles? They're pulling them down now and contracting those valves, closing them up, okay, so that blood does not go back into the atria during this, the ventricle is starting to build up pressure. Once it builds up enough pressure, then the mitral valve the aortic valve and the pulmonary valves will open up, okay, and they will eject blood into the lungs from the pulmonary artery and then into the aorta from the through the aortic valve from the left ventricle. So you have this phase called ejection. Okay. So once the blood gets squirted out, okay, then the ventricle will start to relax again, and it will start to expand. And again, volumes are all going to stay the same. Okay, but these two valves again are going to be closed up until you finally fill the ventricles. And you go back to do the same thing over and over again. Resting heartbeat, this all takes about 1 second or so, about 60 beats a minute, rest, something like that, 60 to 70. So this atrial systole, this atrial kick, again, is 180 degrees out of phase with this ventricular contraction. Okay. So how does this thing work? It's a pretty strong muscle. It's got to eject 150 to 200 cc's per beat out into the lungs, into the rest of the body. And it's got to do that. You do the math. The heart's going to beat some billion times or so during your lifetime. So it has to be a pretty good muscle. It has to work pretty well, and it has to work all the time. So you have not only the muscles, but you also have to have that muscular strength, but you also have to have a good electrical conduction system, and it has to work all the time, every time. So we'll talk more about that in a minute or two, but one of the things that is unique to the cardiac muscle cell, it's also muscle fiber, is the other words. You can see all those actin and myosin that we showed before, these little filaments in here, but there's something that is unique to the cardiac cell, and that's these intercalated discs. There aren't any other cells in the body that have this. They're of a pretty good surface area. And the purpose of the intercalated discs are to provide some means of electrical conduction, electrical impulse from one muscle cell to the next. Okay, so it has to do that. Each muscle cell down the chain has to get an impulse from one up the chain. And it's all very synchronous, and these are very, as we'll see later, it's called tight junctions. Okay, this is one type of way cells connecting each other electrically. There are others that we'll look at later, but it's called a tight junction. The electrical charge just moves right across. Okay, and it has this big surface area to ensure that you get enough charge across to trigger the next muscle to contract. This is called Starling's Law of the Heart. This is named after the person who worked out the math here. But what it means is as you increase the ventricular volume here, as you increase ventricular volume, okay, the heart, the muscle expands, okay, and when you do that, the tension in the wall of the heart, okay, starts to increase as you go up and increase that volume. Makes sense. The linear, one-dimensional analog of this was the rubber band. You take a rubber band, okay, and when it's relaxed, there's no tension in it, but as you stretch it, as you make it longer, you get more tension in the rubber band, right? And the heart works the same. You say, why is that? Well, the heart muscle itself is pretty flexible, kind of like a big rubber band. So as you increase the tension in that wall. And these are arbitrary units, but you can measure them. And so the wall tension increases, but then you get to a point where it doesn't increase anymore. And this is, in the rubber band analog, this is how your rubber band, you can't stretch it anymore beyond a certain point before it breaks, right? It's the maximal tension in that rubber band. Well, the heart doesn't break, okay, but what it does do is not permit any further contraction here. And in fact, if you get way up in here, great big hearts, and there are people with them who have what are called as cardiomyopathy. It's muscle damage to the heart for some reason. Once they get out here, the wall tension starts to drop, and they're not able to vigorously contract their heart anymore. Their ejection fractions, that amount of blood that gets put out into the system each time is very small. And it's generally, if untreated, is fatal. Most of us, most of the time, are operating down here in this linear portion. But people with cardiomyopathies, as they do this, we call the cardiologists call this falling off the Starling curve. That's bad news for the patient because what happens, their heart is just too floppy to beat. Okay, so, but if you hear the word Starling's law, Starling curve, this is what it means. I think I have about 2 formulas in this whole course. Some of you have seen them in engineering and physics. Relates pressure to pressure gradient across a tube or a pipe. Relates the pressure gradient to the flow through the tube or pipe times the resistance. Okay, and resistance, what's that? That's a function of the caliber, the size of the blood vessel, and also has something to do with the friction at the surface, okay, of the wall of the blood vessel. But for the most part, it's the caliber of the vessel. The very small vessels have lots of resistance to flow, the very large ones have very little. So for a given pressure gradient, if you have low resistance, you can have high flow. Okay, pretty straightforward, almost intuitive. But this is really important. This is to the 4th power of the radius of the vessel. In other words, the square of the surface area of the vessel. So you can see that small changes in the radius couldn't read the big changes in resistance. If you make it smaller and smaller and smaller, this is higher and higher and higher by the 4th power. So a little bit of a change here makes a big difference here and can make a big difference here or here. Okay, so this is the analog, this is the pipe analog, where you have small cross-sectional area, you have high velocity of the blood through this little pipe here, very high velocity. Gets up to the capillary level. Now you have collectively, each capillary is pretty small, but collectively you have a huge surface area here. Okay, so the flow goes way down. Okay, the blood, not the flow, but the blood velocity goes way down. And why is that? Why do you do that? Well, you have to give it time for that oxygen and carbon dioxide to diffuse across cell membranes, right? Okay, so you slow the blood way down. Then in the venules and veins, again, it's a much smaller total cross-sectional area than the capillaries, but it's bigger than the arterioles. And so you have a lower blood, you have the same flow. You have to conserve flow. You have to have the same amount coming in as going out, usually. So you conserve that, but your blood velocity is going to be slower. Okay. So again, you can look at it this way, and what they plot out here is a plot of the actual blood velocity as it goes through here. Okay. So if you actually measure these pressures, and there's a way we can do it all throughout all the vascular system, you can measure these pressures. And you can put catheters in the right side of the heart, you can put them in the left side of the heart, you can put them in various veins, and people have done this. And what you find if you put a catheter in an artery that is, say, in the root of the areola, for example, you can see the blood pressure fluctuations during diastole and systole. You can actually measure those. But as you get further and further down, as the vessels get smaller and smaller, that starts to dampen out as you go down the system. It starts to dampen out. So you really don't see it. You can see some pulsation in the capillaries, but it's not anywhere near what you have in the big vessels. And so finally, when you get down into the veins down in here, you don't see it at all. And look at the pressures here. From 80 to 120 with a average, or they draw a mean here, right between the two of 100. Get down in here and look at down a millimeter of mercury in the superior and inferior vena cava. It's really small compared to down here. So, and we'll see how we can compensate for these low flows in a minute. Lots of fluctuation here, and then get way down in here. And they have this analog here, this driving force here, resistance here, and then you have low pressure out here. So how do we get the blood back against that pressure? Well, you know, where are your feet? Your feet are way down here. You have a gravitational pressure head between your feet and your heart, right? So you got to overcome that somehow. And what happens is that the action when you breathe, remember that diaphragm in the pulmonary system? When you breathe, blood is literally kind of sucked up in the thoracic cavity from the lower parts of your body. So breathing is important. Okay, that helps get the blood back. Okay. The other thing that helps get the blood back is muscular movement. Okay, now we're moving around a lot of the time. Right now you're sitting down, but eventually you'll get up and go out, right, and walk around campus and stuff. So it's that muscular contraction that helps move the blood back from your legs back up into your abdomen, and then this suctioning action moves the blood back up to the heart. Okay. So you remember those valves in the veins? They're passive valves, not like the mitral valve and the tricuspid valve in the heart. Those get pulled shut. These just get open and shut by virtue of blood flow. So when you're moving blood up here, it doesn't go back when you stop. So, and there's these valves in the veins all the way up. Okay, and so they will open during when the flow needs to be back to the heart, and then they'll close back up so you don't have backflow. So that's how it happens, even under these very low pressure conditions. You see them here. They're open and flow in this direction and closed with retrograde flow. You saw the electrocardiogram. Okay, this is have a guy hooked up to electrodes and show you how those are placed. But the idea here is you're going to be looking at all the so-called polarizations and depolarizations of the heart as it goes through the cardiac cycle. Okay, again, this is an electrical signaling event, and you know it can be very helpful to see any abnormalities in that signaling, so that you can diagnose maybe what's wrong with somebody's heart if they're having heart problems. So you can look at changes in this EEG or EKG rather, or ECG. You can look at changes in it to look at parts of the heart that aren't getting the proper blood flow, for example. So what happens? You can measure these voltages. You put these electrodes on the body surface, okay, and you record them as a function of time. The time scale here that you see here is on the order of about a second at rest. Something like that. Cardiac cycle is about 1 second at rest. So what happens? You get a little bit of what is called depolarization, okay, of the atria, which is responsible for a wave that they call the P wave. Okay. They're named arbitrarily after letters of the Latin or Roman alphabet, for reasons I don't know, but this is called the P wave. Usually there's no polarization here, and you get a little atrial kick, a little electrical signal here. Once you get the ventricles start to contract, you have this so-called QRS complex, which is the ventricle depolarizing and atria repolarizing during this phase. And then the ventricle depolarizing as well. So this is a big signal. This is when the heart needs this big kick and beats, and you get a big electrical signal in this QRS complex. Finally, the ventricles will repolarize here, you know, a fraction of a second later, a few hundred milliseconds later. When people do ECGs or EKGs, they measure a bunch of things. They don't care about so much the amplitude of the voltage. What they do care about is the direction of it. So this QRS complex in certain circumstances may be in the wrong direction compared to its normal. Okay, so look at that. You look at the timing between the P wave and the Q wave here. And it's called the PQ interval. Okay? So, and you can measure this interval here. Both of these, the length of these can tell you something about the person's heart. Usually it's how the person's heart is actually responding to the electrical impulses. And these are influenced by things that may be wrong in the electrolytes in your blood, for example. So you can get a lot of information out of this EKG. Again, this PR interval should be about 120 to 200 milliseconds. The QRS complex normally should be under 100 milliseconds. If it's wide, could indicate a problem. This ST segment should be under about 400 milliseconds. So, they can measure all these things and get a lot of parameters. One of the neat things about automation these days is that back in the old days when I started doing this in internal medicine in the early 80s, you sat down with a paper recording and calipers and you measured off the scale, the time scale on the EKG. They don't show you that here, but you measured it and then you wrote it down, and that was your report. All this can be automated now. You guys in biomedical engineering, I bet you're going to have a course in signal processing at some point. That's what these things do. They can automatically process these signals, extract these parameters from them, and just spit out in the report, and you can spit out a diagnosis for you if you want. So how does that happen? This polarization and depolarization I was talking about, you can actually do this experiment in either muscle cells, but mainly people use nerve axons, for this, and we'll talk more about those later. But the axon is how the nerve conducts an electrical impulse. And there are certain animals that have big axons that you can actually put electrodes in. And, when this part of the muscle fiber, for example, is just resting, okay, you get a zero voltage, okay, it's in a certain state of polarity. But as this impulse transmits down through the muscle fiber, you can see how you're going to get a deflection here as it depolarizes. And that's a positive deflection here on your needle. Then as it goes back, in this area here, goes back down. And finally it goes negative here as the pulse starts to pass one electrode, not the other. And then finally goes back to the resting condition. Okay, so that's how this propagates down the muscle cell, and this is the recordings that you get. And you say, well, that's cool, but we can't do this on an individual muscle cell basis, right? Can't do it. Okay? You can only do it on, say, either one cell at a time or all of them at a time. And when you do them all at a time, it's called the electrical vector. It's a summation of all of the directions of these electrical signals. It's called a vector. So there is something called vector EKGs or vector electrocardiography. Don't need to talk about that, but that's the principle. So you can watch the motion of that vector as a function of time. And this example, again, just demonstrates, how this EKG signal is related to the different phases of diastole and systole. So I think you need to know something about arterial blood pressure and arterial blood flow, because this is what supplies all your organs. And so you've got to have the right flow and you've got to have the right pressure all the time. If your pressure's too low and your flow too low, then you don't, say, perfuse or have a blood supply in your brain. And you do that for about 4 minutes and then you die. So, very important. So if we want to, influence arterial pressure, okay, you can make it go up. Okay, and these are the ways to make it go up. You can increase your stroke volume. Okay, stroke volume is the volume of blood that's ejected with each beat of the ventricle. If you're resting, it will be one value. If you get up and exercise, you will eject more blood for each fraction. Okay, each stroke, you eject more blood. You can do that. The other thing you can do is increase your heart rate. And that also happens, right? When you exercise, your heart starts beating faster. So both of these, if you take your stroke volume times rate, that's flow. So that increases a quantity called your cardiac output per minute. Okay? And then this increases the volume of blood that goes into the arteries. This increases your arterial blood volume flow, and your arterial blood pressure will go up. That's good. So the other thing, though, that you can do is to make it go down, you can increase your blood viscosity. Y'all remember Reynolds numbers and stuff like that? I think it has something to do with the viscosity of a fluid. What makes blood viscous? All those red cells, right? Okay. So there's a medical condition, it's called polycythemia rubra vera, in which people make too many red cells. Their bone marrow is popping out too many red cells. Way abnormal fraction of red cells in their blood. So your blood viscosity can go up. The other thing is if you squeeze down the arterioles, that'll cause your peripheral resistance to increase and your flow goes down. Okay, and that will lower your, the arterial runoff, this decreases. So all this will increase your arterial blood pressure, especially this. These people have strokes and heart attacks and stuff like that. The other thing that can increase your blood red cell count is smoking. Okay, you're inhaling carbon monoxide, and so the body compensates for your smoking by increasing the number of red cells in the bloodstream. So that's another reason smokers have heart attacks and strokes. There are so-called baroreceptors. Okay, we heard about chemoreceptors in the aortic arch and in the brainstem. Those sense carbon dioxide for the most part. Baroreceptors sense stretch in blood vessel walls. And the word baro, this prefix here means pressure. So you have pressure receptors. Okay, and as your blood pressure increases and decreases, these things will respond. Okay, if you increase arterial pressure, okay, that's detected, goes up to the brainstem. Brainstem influences a nerve. It's called the vagus nerve. That, again, that influences your heart rate and how impulses are conducted through the heart system. Okay. So if you drop your arterial pressure, the opposite happens. Okay? It will start to increase your heart rate, increase your stroke volume in response if you have a drop in your arterial pressure. Why would that happen? Say you had an injury, you were in a car accident, unfortunately, and you cut in an artery, your blood pressure may drop way down, so your brainstem will tell your heart, to beat faster to compensate for it, which may not be real good. You're just pumping more blood out of your body. Hope you clot it off. So it'll respond to either arterial pressure that's increasing or pressure that's decreasing. Again, this is a complicated system. We won't talk much about it right now, but all these things in your brainstem will influence the so-called autonomic nervous system. That's your involuntary system. You cannot voluntarily either increase or decrease your heart rate just by standing and thinking about it. You can't do it. Some people claim to be able to reduce their heart rates. These people that sit on top of mountains and they chant or something. They claim they can do that. Not really. So you can't really do it consciously. But you can do things like relax, and that will help your brainstem do some of these things. There's a lot of nerves where you have both, through this vagus nerve, you have signals leaving the brainstem, and through some of these other branches of the vagus nerve, you have it coming back, okay, and influence the brainstem by these baroreceptors. And you find them in the aortic arch, and strategically placed where you need them up in the carotid arteries. Okay, so the other thing too that influences, as we talked a little bit about before, is your blood carbon dioxide. And these chemoreceptors are all over the place as well. We talked a little bit about that in the pulmonary part. The other thing that happens is that this is one of those systems that's just incredibly redundant. And you have a lot of ways of influencing blood pressure that don't have anything to do, much with, say, the brainstem or other things. You can control blood pressure fairly locally, okay, within the organ itself, or some organ or another producing a hormone that can either raise or lower your blood pressure. I won't go into a lot of detail now. We'll do a little bit more of this when we talk about the nervous system and the endocrine system. But both your heart and your kidneys can actually produce hormones that can influence your blood pressure. And for example, there's a hormone that is called angiotensin. And what does that mean? It means something that contracts blood vessels. And there's a complicated system where you can take angiotensin, convert it to yet another enzyme, and then finally get your end action, so that you can influence all these points in this enzyme activity. So again, this is a little more complicated we need to talk about, but just be aware that this can happen. The heart can produce also something called arterial and natriuretic hormone. And that can influence both your kidneys to produce other hormones. So it's, again, one of these systems where you have multiple points of control. We saw that, I think, in the first or second lecture. This is something you can do. You can take red blood cells out of the patient, okay, and you can tag them with a radionuclide, re-inject them, wait about 10 or 15 minutes till they get all circulated, put the patient under a gamma camera, and take individual gamma camera frames. In this case, they've taken the cardiac cycle and divided it up into 16 different frames. And then you can play that back and display it in a movie like in a loop. So this is taking a bunch of cardiac cycles, averaging them up, and then playing it back in a movie loop. It's called officially called a cardiac gated blood pool study. But people early on decided to call it a MUGA. It stands for multi-gated analysis. Okay. So everybody calls it a MUGA. Okay, so you hear somebody say, oh, he needs a MUGA. This is what they're going to be doing. It is a gold standard, actually, for measuring ventricular ejection fraction. So you can see, if you were to take your computer and interrogate this area of the ventricle, and this is in 2 dimensions, and you've taken all the counts that you accumulate during diastole and compare it to all the counts you accumulate during systole, and you do a little formula, and you can actually calculate the percentage of blood that's ejected with each beat. And for most of us at rest, it is not anywhere near 100%. It's about 55 to 60% at rest. If you exercise, it can go up close to 100. Okay, but normally it's about 55% or so. So you can do it, and this is the best measure we have right now. You can do this with ultrasound. You can kind of measure ventricular volumes, although not very well. You have to apply mathematical formulas for an ellipse, volume of an ellipse, which isn't trivial. And it's hard to do. This is easy. And so it's still the gold standard. So that's the MUGA. The other thing you can do, if you want to look at blood flow to the myocardium itself, okay, it's important that you be able to look at blood flow, okay, because that's what, if you don't have the right blood flow, your myocardium will die. So they use radioactive agents. In this case, this is ammonia, NH3. The nitrogen has been made radioactive. This is nitrogen-13. And ammonia is highly extracted by heart muscle. And you say, okay, well, so what? Well, if something's highly extracted and then gets trapped metabolically in the heart, what you got is a map of blood flow. Okay, if something goes in, doesn't come back out, that's your flow. So we have an area here. You're looking at the heart along its axis now. So this is, I think this is your lateral wall over here. This is your septum here. You have an area of the heart that doesn't get any flow. That area is called ischemic. Okay, we don't know it's dead. It's infarcted if it's dead, but we don't know. This could be could be ischemic or infarcted, but it's got low flow. Okay, so your heart, when it's using energy, how does it get its energy? Most organs get it from glucose. Heart gets from fatty acids. So it only starts to use glucose if under ischemic conditions. Okay, so what you do is you take an analog of glucose, it's called fluorodeoxyglucose, and you put it in and you see that it's taking up a lot more glucose than normal myocardium because of that lack of oxygen. It's unable to oxidize fatty acids in this area, so it switches metabolism to take up glucose. So that's something you can do. If you just want to measure flow, there's easier ways to do it. This takes a PET scanner to do this. And you have to have a cyclotron. There's nitrogen-13. It's a half-life of 10 minutes. You've got to make it on site. Can't ship it easily. So if you want to look at flow down the axis of the heart, you have to remember that the ventricle is tilted in this kind of configuration here. So if you just do transverse sections of the body with your PET scanner or your SPECT scanner, if you just do those, it's hard to interpret it. What you really want to do is be able to look, have your axis of your sections be down the heart axis, so not tilted compared to the body axis. So what you can do is have the thing do a bunch of fancy math. You look at some transaxial sections, draw a line through the axis here, and then do it in the other plane, 90 degrees, and draw another line. And the computer can use that information to figure out how to take all the data in the images and make it go down the axis of the heart itself. So it's called this orientation. And so we have these names that they call these planes in the heart. Horizontal long axis is like a sagittal plane. The oblique transaxial is called a vertical long axis. That's like a coronary section. And this is like a transverse section. We have a short axis thing. That's what the cardiologists call them. So you can do it, and you can see the different changes of the heart right down the axis. So you have a short axis view here, long axis or coronal view here, and a kind of a sagittal view here. And what you're looking at is maps of flow at stress and rest, stress and rest, stress and rest, okay? And the idea here is you want to compare the flow of blood at rest versus the flow at stress. And when you do that, you can figure out what areas of the heart aren't getting blood flow. It's kind of a unique process that we can do in nuclear medicine. You can't do it any other way. The way these are oriented on the short axis, the apex of your heart is down here, and the base of your heart is up here. Here's your apex of your heart. And in these, here's the apex of your heart, and the base of your heart is here. The base of your heart is the so-called valve plane. It doesn't take up much of your flow agent. This is a radioactive agent that, like ammonia, goes into myocardium and is trapped. And so you get flow. And so you can compare them. And this particular instance, you will look, say, on your short axis here at stress. Okay, you see a defect here in this anterior wall. That defect kind of fills in, okay? It's kind of subtle, but it does fill in at rest. That means the person, as their heart increases its heart rate and its oxygen needs, it's not being met in the apex of the heart. But when you rest, it is. And so that means the person's got something wrong, that area of the heart. Well, it's really pretty good to be able to do this. You can even take these and make a movie out of them. And not only can you see flow, in this case, this is fluorodeoxyglucose. Okay, you can see this in the short axis. This is your long axis view here. And you can see this area of the heart. It should be pulling in like these. It would be pulling in normally in this direction. It's just sitting there. So not only is the heart not getting the right blood flow there, it's also not moving. Okay, so what does that mean? Well, you're not injecting as much blood as you could. So that's kind of why we do this. We take advantage of, we exploit, take advantage of these physiology concepts and apply them to get a diagnosis. And that is that. Any questions about that stuff in the remaining 3 minutes? That's a lot, but we'll kind of review some of the things that we saw later on when we get into the gastrointestinal tract, endocrine system.